researching PPE. They are researching in PPE policies and healthcare worker mortality in the UK, US, Germany, and New Zealand during COVID-19. So feel free to start whenever, guys. I think you should also be able to screen share.
All right, good morning. Thanks so much, first of all, to Jan and to Caroline, I'm not sure if they're still here, for the really insightful presentation. I'm just going to share screen right now. And team, if you're ready, or if you're not, just let me know. Okay. Is everyone able to see the screen? Okay, great. Just give me one moment. Sorry, this is. All right. So good morning. We are the BBI's Global Health and Health Policy Research Team affiliated with the UCL European Forensic Society. And this is our presentation on the following research topic: keeping our frontline safe, linking personal protective equipment policies and healthcare worker mortality in the UK, US, Germany, and New Zealand during COVID-19. Our team members are Arena, Kat, Trisha, Z, Natasha, Jamie, and myself, Yanning. We're undergraduate students at UCL with diverse backgrounds in law, public health, medicine, and the social and political sciences.
So to talk a little bit about why we're studying this, let me introduce you to Thomas Harvey. He worked as a nurse in a London mental health care facility. He was working without any PPE, barring gloves, in March 2020 when he fell ill with COVID-19. He had dedicated over 20 years of his life to service in the NHS and was described as selfless and devoted to his patients, chatting with them about the weather and football and asking each how their night had been. Thomas Harvey passed away at home at the end of March and is survived by his wife of 22 years, 7 children, and 3 grandchildren. This is the story of one. According to Amnesty International, there have been over 17,000 healthcare worker deaths since the beginning of the pandemic. But in our research, we're dealing with numbers, of course, it's a quantitative study, but the fundamental motivation behind studying this is to understand, analyze, and address the factors contributing to this unimaginable loss. As the WHO has stated, this will not be our last health emergency, and so we need to explore in depth the ways in which we can be best prepared in the future and how we can best protect our frontline workers. PPE is a modifiable factor in this equation, and as a demonstrative means of readiness, the issue of environmental sustainability has also been raised over the course of the pandemic, with hospitals generating increasing amounts of waste. The exploration of reusable PPE is more pertinent than ever as it tackles the concerns of both waste and also the threats posed to healthcare worker safety when single-use PPE is inevitably reused due to lack of supply. Finally, the importance of studying the impact of PPE is not simply a moral undertaking. The provision of sufficient and suitable PPE is a codified legal obligation in the 4 countries we've investigated, and thus scrutinizing the effectiveness of PPE policy is a crucial attempt on all fronts.
COVID-19 is part of the family of coronaviruses, which are named for the crown-like spikes on their surface. These are called spike glycoproteins, and they're very important as they're how COVID-19 invades host cells, using them to bind to host receptors. Like other coronaviruses, though, its primary route of transmission is through direct or indirect contact with respiratory droplets. These droplets can be released when an infected person sneezes or coughs, and they can enter the body via mucous membranes in our noses, mouths, or eyes.
A significant modifiable factor in COVID-19 risk for healthcare workers is their use of and access to protective equipment. Personal protective equipment, PPE, is the term used to describe items to be worn or used for protection against health or safety risks. In the COVID-19 context, it is primarily required for the purposes of guarding against transmission between people through close contact and droplets. In this presentation, PPE includes medical masks, gloves, and eye protection, items which are distinguished from the face coverings that the general public is advised to wear. But it may be helpful to first review the literature surrounding evidence on PPE policy effectiveness during outbreaks of previous coronaviruses, namely severe acute respiratory syndrome, or SARS, and Middle East respiratory syndrome, MERS. The results of 2 studies conducted in Hong Kong and Vietnam demonstrated that masks alone were inadequate in containing and eliminating SARS transmission among healthcare workers. As such, it is crucial to consider other potential risk factors, including perceiving the amount of PPE to be inadequate, having less than 2 hours of infection control training, and inconsistent use of gowns, caps, and goggles. The academic literature on PPE policy effectiveness for the transmission of MERS is accompanied by the general understanding that, given its phylogenetic and immunologic similarities to SARS, the guidelines developed for SARS can also be followed for MERS cases.
Continued research into the effectiveness of PPE provisions on the transmission of SARS-CoV-2 has been conducted during the pandemic and have reached similar conclusions made by literature on previous coronaviruses. A systematic review and meta-analysis of 172 observational studies across 16 countries found the use of disposable surgical masks, reusable 12 to 16-layer cotton face masks, as well as N95 and similar respirators were associated with a significant reduction in risk of infection. Stronger associations were found in healthcare settings, and eye protection was found to be associated with a 16% increase in protection to infection as well, further suggesting the need for increased PPE provisions for healthcare workers. According to case control studies, not all masks are equal though, with staff working in high-risk specialties of intensive care and anesthetics, and were also provided with FFP3 masks, experienced no mortality compared to specialties that were provided with weaker PPE provisions. A simulation of COVID-19 transmission using a smoke chamber model has also been conducted to simulate a hospital environment, and found that fluid-resistant surgical and FFP2 masks provided no protection to respiratory particles, with only FFP3 rated face masks being effective at providing respiratory protection to the user. As such, FFP3 and N95 respirators should therefore continue to be prescribed to healthcare workers whenever possible, given the significant quantity of evidence suggesting its superior efficacy in protecting the transmission of SARS-CoV-2. However, further research should be conducted in order to further validate this claim.
The literature concerning healthcare workers' experiences focused on the twofold impacts that they felt when confronted with PPE shortages and a lack of training in its use. Firstly, they narrated extreme feelings of insecurity when working with suspected and positive COVID-19 patients, due to not only a lack of adequate PPE, but also a lack of training in its use and the spread of misinformation about the virus in general. Many healthcare workers reported that the fear of infection resulting from insufficient PPE was the primary cause for them not reporting into work. Secondly, the lack of PPE and training not only impacted healthcare workers' susceptibility to disease, but also had a severe impact on their mental health. The already stressful situation of working during unprecedented times was further compounded by this lack of PPE and information. Anxiety and fear about catching COVID-19 and passing it on to family members was cited as one of healthcare workers' most prominent feelings. Issues arose even when PPE was available. For example, healthcare workers narrated issues communicating with colleagues through PPE, discomfort from wearing ill-fitting PPE, and suffering from dehydration and a lack of breaks so as not to use up already scarce resources.
So healthcare workers, or HCWs, especially those in patient-facing roles, are vulnerable during the pandemic because of their proximity to disease. There's evidence that they encompass a substantial and disproportionate percentage of infections and deaths from COVID-19 compared to the general public around the world. And the risk of infection and risk of severe outcomes is further stratified by the profession, their specialty, and characteristics such as age, sex, prior health, and their ethnicity. So research investigates the relationship between PPE guidelines and healthcare worker mortality from COVID-19 in the UK, US, Germany, and New Zealand from first case dates in those countries until July 1st. We chose these countries because although they all had similar levels of healthcare resources and operate somewhat similar governmental structures, they had very different responses to the pandemic, and also because data from these countries was more available and was in English or could be easily translated by team members. We chose the study period because data was more available during that time, both PPE and healthcare worker mortality. We hypothesized, therefore, that strict PPE guidelines are correlated with fewer healthcare worker deaths.
For the methodology section, we compiled healthcare worker totals from census and survey data. We only selected roles which we classified as patient-facing based on ONS estimates of exposure to disease and physical proximity to others. For healthcare worker deaths data, we collected them from various sources, including official sources, Medscape, and the Kaiser Family Foundation from the United States. For the standardization, row counts of healthcare worker deaths were divided by the total number of healthcare workers in each country, then multiplied by 100,000. Here you can see the data sources we used. As you can see, they cover the periods 2018 for Germany and New Zealand, 2019 for the United States, and 2019-2020 for the United Kingdom.
Great, so now we're going to briefly explain the methodology used to code the PPE policies numerically. So because we use national PPE guidelines from different government health authority websites in all 4 countries, we had to find a way to compare them numerically. We quantitatively coded them with 1 or 0 as follows. So first of all, we classified whether countries considered or whether countries advised the use of higher grade respirator masks or just surgical masks during non-AGP and AGP procedures. AGPs being aerosol deadening procedures, these are just procedures that are considered to be very high risk with relation to infection from patients. And we classified 1 if the respirator was advised and 0 if only a surgical mask was advised. Then we looked at what exactly countries classified as AGPs. So did they classify CPR, for example? And did they classify the induction of a cough during medical procedures? And it was 1 if they did and 0 if they did not. Then we looked at the extent of eye or face protection for healthcare workers. So did they recommend, for example, that all healthcare workers should be provided with face shields and goggles, or only that some should be provided with them based on risk assessment? Finally, we looked at how they used gowns. So some countries advised that healthcare workers should use long sleeve gowns that are fluid resistant, whereas others advised only elbow length plastic aprons. Now looking at the results from this coding, we can see that in order, the US, Germany, New Zealand, and the United Kingdom have the strictest guidelines, with the US having a full score across the board. Now this is with the assumption of equal weighting, which may not be the case in practice, but for the ease of our analysis, this is what we chose to use.
Now, all this data from Medscape was web scraped and inputted in an Excel spreadsheet, and thus were then categorized by country. We decided to show non-standardized figures first to show the scale of the issue, and then standardize the rate based on the total number of healthcare workers due to differences in the proportion of healthcare workers to the population of each country. We acknowledge differences in PPE provisions between medical professionals working in different departments. As this should average out between countries, though, we are still confident that this choice for standardization was the most appropriate. We also directly compiled population COVID-19 case and death standardized counts for the duration of our study period from our Walden data.
Great, so now we're going to discuss our results with a focus on our original hypothesis. Here again are 4 countries ranked by PPE guidelines stringency, combined with data on the number of healthcare worker deaths during the study period and deaths and cases from COVID-19 in the general population. So first looking at the US, although it had the strictest guidelines across the board, it also experienced a very high number of healthcare worker deaths and similarly the very high case rate and death rate. We hypothesized that this may be because of the limited provision of PPE itself, leading to less adherence of the guidelines. For example, the reusing of PPE where it was not advised originally. Then if we see Germany, this data shows a more expected pattern where strict PPE guidelines are linked with a minimal healthcare worker deaths and more favorable national pandemic situation. So when provided with higher grade protection, healthcare workers are less likely to fall ill. Then looking at New Zealand, where PPE guidelines were not as strict, we can see that the fact that there were lower rates of community transmission. So as you can see, the deaths and cases were not very substantial in this population. So therefore, not as much protection was necessitated in typical hospital settings. Therefore, healthcare worker mortality was basically non-existent, though we realize that this may also be because of New Zealand's small population. Finally, looking at the case of the UK, which shows a similar pattern to Germany, there were lenient guidelines from healthcare authorities, and this contributed to a very high number of healthcare worker deaths, especially when standardized. And though the death rate was, the case rate was not as high as the US, the death rate was very high in the UK. Though the UK and New Zealand differed vastly in healthcare mortality, these are the conclusions we reached. So we reiterate that the relationship we've investigated between healthcare worker mortality and PPE guidelines is very complex and includes confounders. But that if we're looking at the relationship between PPE and healthcare worker mortality, we should consider PPE guidelines, the outbreak severity in the country, and PPE ridden alike. So next, we're going to give a brief overview of the latter point, explaining each country's approach to PPE provision and the challenges that they faced during the first wave of the pandemic.
An examination of the large-scale questionnaires published by national health organizations and academic researchers in the UK found that the availability and stringency levels of PPE were inadequate from mid-March to late June. For instance, a national questionnaire published in the Elsevier Public Health Emergency Collection, which surveyed NHS healthcare professionals during the first 2 weeks of April, revealed that 2/3 of the respondents were of the view that there was not enough PPE available. With that said, there were some signs of improvement as time went on. This can be seen in the series of surveys conducted by the British Medical Association. On April 6th, only 44.64% of the respondents reported that they never felt pressured when working in an AGP area to see a patient without adequate protection. In the June 18th report, however, this percentage had increased significantly to 74.90%. Still, however, the overall data remains concerning and suggests that PPE provision in the UK was inadequate.
To move on to the US, analyzing documents from several federal agencies and healthcare worker unions, the PPE provision in the United States has been insufficient in meeting demand. Preemptive calculations of required demand of key items such as N95 respirators severely outstripped supply as early as February 2020. These supply issues further intensified as time progressed due to wide-scale global supply chain disruptions. The US Conference of Mayors reported in March that 88% of mayors and city officials surveyed claimed that they didn't have adequate supplies of PPE to protect medical personnel and first responders. The National Nurses United's national surveys, conducted over the course of the pandemic, provided insight into the experiences of thousands of nurses across the states. In the April wave of the survey, 72% of nurses reported having cared for suspected or confirmed COVID-19 cases with exposed skin or clothing. April through July, around 88% of surveyed nurses cited wide-scale reuse of PPE equipment. In July, the CDC published official guidelines for optimizing PPE equipment when facing depleted supplies, further suggesting that the pressures of demand had not been met even after undertakings such as Project Airbridge, which were meant to bolster domestic supply.
An analysis of Bundesregierung publications demonstrated that Germany already had several pandemic contingency plans in place for containing a virus and also regarding PPE provision. They furthered this PPE provision with a procurement task force and a force aimed at increasing national and EU procurement chains. Unfortunately, we were unable to find surveys detailing healthcare worker responses, nor any from national healthcare institutions. However, news articles and government announcements demonstrated that these measures have been insufficient and that hospitals across Germany suffered from a lack of PPE. In an attempt to support healthcare workers through PPE shortages, hospitals and other institutions also published guidance on how to appropriately reuse PPE that was only intended to be single-use, a fact which only emphasizes the lack of PPE that healthcare workers had to cope with.
While New Zealand had the fewest infections in the general population and a non-existent proportional mortality, there were some issues worth mentioning when it comes to PPE provision. First of all, decentralized provision systems caused confusion about the exact amount of PPE available at the onset of the pandemic. District health boards and the Ministry of Health each held their own supply for some items and didn't report to each other. Pandemic plans were based on previous influenza pandemics and bird flu pandemics, which were deemed unfit to deal with the COVID-19 pandemic. There were some reports of N95 masks that had been found unfit for use. PPE stocks were based on outdated population statistics. The population had risen by 19% since the initial plans were formulated. Additionally, there were no healthcare worker surveys conducted. However, some concerns over PPE distribution were raised by Keri Nuku, the vice president of the nurses organization. Finally, because data on New Zealand was limited, this section was based on secondary sources from an audit report and unofficial sources.
We also investigated the effect of differences in face mask fit testing policy. This is important to check because fit testing makes sure that a given mask is effective when worn right. It is used to make sure a given mask fits a person's face correctly, that there's a sufficient seal, stopping particulates or droplets entering the mask. Ultimately, however, there weren't really any notable differences between the countries. There were some differences in quantitative test thresholds, but in the end, no country had strict regulations on who carried out the fit testing.
Finally, though the primary focus of this research is the impact of PPE policies on the safety of healthcare workers during COVID-19, we also looked at other hospital-wide and nationwide policies that also affect infection and mortality in this population. So first, testing, which counters absenteeism and ensures HCW safety at work. This may enable people who are self-isolating unnecessarily to return to work and keep workers safe at work as well. However, we found a lot of variation in the comprehensiveness and quality of testing policies for both frontline staff and the general public in the 4 study countries. However, all nations examined took a priority-based approach, where healthcare workers were allowed access to more testing because of their infection risk. And we also advised a similar approach. Now talking about very general infection control procedures. One suggestion already implemented in East Asia has been the zoning of hospital areas so that staff can avoid high-risk areas when not wearing the appropriate PPE. In addition, very standard infection control procedures such as environmental disinfection, hand sanitizing, social distancing, and coughing and sneezing as per public health guidelines is crucial in both hospital and wider settings. Finally, it's really important to mitigate adverse psychological consequences of healthcare workers during the pandemic so that morale and resilience are maintained. Signposting staff to mental health support services, providing training in self-care and management of difficult emotions and situations, as well as reducing social stigma, can support staff well-being. In addition to improving well-being and general health, mental health interventions also improve adherence to infection control guidelines for healthcare workers, also limiting the risk of infection.
Moving on to the strengths and limitations, this research has for the first time taken a direct quantitative approach to comparing PPE guidelines during the COVID-19 pandemic and linked this to healthcare worker deaths. Its strengths lie in its detailed examinations of AGP classification, eye and face protection, and fit testing availability in the 4 nations with heterogeneous responses to the outbreak, as well as in its standardization of healthcare worker deaths within a defined study period. With that said, though care is taken to strengthen data quality and completeness in this analysis, some limitations remain. As for the scope of the research, this study has been limited to 4 high-income Western countries from March to July 2020. As such, the results cannot be generalized to other regions of the world. Additionally, the results do not take into account other important developments in the impact of the pandemic, which have occurred beyond the study period, and also does not consider social care workers who have faced similar issues with PPE supply and work on the front line.
In regards to data quality, firstly, there are possible inaccuracies in healthcare worker death figures due to the categorization of patient-facing roles based on responses to the ONS annual population survey, which is a survey conducted with only UK respondents. This limitation is exacerbated further by the fact that there is no universally agreed upon definition of what patient-facing constitutes. Another limitation lies in the matter of incompleteness of total staff numbers. The datasets we consulted are themselves estimates of the composition of the healthcare workforce and may suffer from inaccuracies which would have been translated into the study. There are also a few difficulties in interpreting cross-country PPE guidelines due to the language barrier and differences in information availability. One of the most notable limitations is the fact that the source for AGPs in New Zealand is from outside the study period. With all this in mind, due to the observational nature of this analysis and possible limited variable bias, we cannot infer certain causation for the investigated association.
To conclude, although we found no direct or dose response relationship between PPE policies and healthcare worker deaths in the UK, US, Germany, and New Zealand, this research has demonstrated that myriad factors such as PPE vision, facility infection control guidelines, and country-wide pandemic management strategies work in conjunction with government guidelines to impact the safety of healthcare workers during COVID-19. Now, given the scientific evidence for the protective power of higher grade PPE as we've demonstrated, we recommend greater efforts targeting provision and evidence-based guideline development for the duration of this COVID-19 crisis and for future pandemics as well.
We have identified that further research is required in 2 primary areas: sustainable PPE and how disease disproportionately impacts BAME healthcare workers. Sustainable and multi-use PPE has the potential to reduce waste disposal. Currently, single-use PPE, once it's contaminated, is difficult to dispose of and most of it ends up in landfill sites. Sustainable options could greatly reduce this environmental impact. Additionally, multi-use PPE has been shown to be absolutely vital during this current pandemic. Multi-use PPE, so PPE that can be sterilized and then used a second time, could prevent resource scarcity during future pandemics. The second topic that we have identified as requiring further research is the unequal impact that disease has on BAME healthcare workers. Surveys made this particularly apparent in how inadequate PPE provision disproportionately impacts healthcare workers from ethnic minority backgrounds, a topic that urgently requires further research.
Thank you so much for listening. Really appreciate the time. And we also wanted to thank the BBI trustees and admin team for supporting us throughout this research process. We're grateful to our peer reviewers and our topical advisors, Dr. Jillian Higgins, Dr. Jasmine Yue, and Dr. Maxine Chan. We're also grateful to the charities MedSupply Drive UK and MedSupply Drive Scotland for providing us with translated PPE documents during the research process. Thank you so much. And please ask any questions that you might have.